Eberhard Standl from Germany. He is a professor of medicine specializing in endocrinology and angiology at the Munich Diabetes Research Group at Helmholtz Center. And Dr. Standl's principal areas of research include diabetology, action and degradation of insulin, and epidemiology of cardiovascular diabetes complications. Previously, Dr. Standl was the director of Department of Endocrinology, Diabetology and Metabolism at the Academic Hospital Munich, Schwabang, and he also worked at the world-renowned Joslin Diabetes Center in Boston, Massachusetts. Dr. Standl served as a member of the Scientific Advisory Board at Lifestyle Innovation Corp. Since May 2014, Dr. has served as the president of German Diabetes Association, German Diabetes Union, and International Diabetes Federation in Europe, as well as vice president of the International Diabetes Federation and ESAD. So now he will be delivering his lecture on insulin resistance, a key factor in the progression of type 2 diabetes and benefits of thiazidine-diones. Dr. Standl, please deliver your lecture.
Hope I can manage here. Are you seeing my slides?
No, not yet.
No, sir.
Not yet? Okay. I have to get out here. Should be here. So am I on with the slides?
Yes, now
Yes,
we
sir.
can see. Make it, yes. Make on slideshow.
Okay. So thank you very much for this great opportunity. I'm very, very pleased to be able to discuss insulin resistance, a key factor in the progression of type 2 diabetes and benefit of PPAR-gamma agonists. Thank you very much for the invitation, Dr. Panchi. We are old friends, and it's really a pleasure to be at this meeting. So, my disclosures in this regard, active roles in a number of cardiovascular outcome trials, including the proactive trial where pioglitazone, a PPAR-gamma agonist, has been evaluated. Clearly, I will come back to that also during my talk. So let's get started then. I heard earlier excellent talks on the complexity of the pathogenesis of type 2 diabetes at that meeting. And this is the famous ominous octet formulated by Farinini and Frank, indicating that 8 different organs are contribute to hyperglycemia, the development of hyperglycemia. So it's very useful when it comes to therapy to have drugs available with multiple effects in this complex ominous octet, in particular PPAR-gamma agonist stopping lipolysis. And so this is a very important feature, including also increasing glucose uptake. So insulin sensitivity is upregulated. And also clinically very important, hepatic glucose output is decreased. So PPAR-gamma agonists are very effective in reducing fasting hyperglycemia. And so these are complex modalities giving benefit to reducing hyperglycemia in type 2 diabetes. So in a way, we are shifting the disordered balance between a reduced and delayed insulin secretion, reaching the target organs of insulin with a reduced efficacy. And this, of course, is counteracted by signals, in particular coming out of adipose tissue, making or rendering the insulin target tissues more resistant. And so this is the benefit one can really make available in therapy using PPAR-gamma agonists. And this would be a first outline on the PPAR-gamma agonist. They clearly lower glycemia, especially fasting hyperglycemia, as I tried to point out. They improve insulin sensitivity, induce a healthier fat, so more HDL cholesterol, adiponectin, the insulin sensitizing hormone is released in higher concentration, triglycerides reduced, and also effects on non-alcoholic steatosis hepatis, fatty liver disease, anti-inflammatory, anti-clotting, and anti-proliferative capacity, which can be picked up by measuring biomarkers. And clearly, they also improve endothelial dysfunction by more release of nitric oxide. And along with that, we have also reduction of blood pressure. But as we all know, there are downsides in terms of weight gain, edema, bone fracture, and congestive heart failure. And these are also very important aspects which we need to control in order to use those drugs at the best of their effects. But it can be done. This is my message there. Now, first of all, sustained glycemic control. Beta gamma agonist probably is one of the best options to give you a very durable glycemic control over years, and this is derived from two of the thiazolidine SPI and rosiglitazone. As you can see, up to 4 years or even 5 years, you have a very sustained effect with those insulin sensitizers, and this is really the best you can get from any of the other drugs, including in the proactive trial. And I said I will come back to that. And in fact, in the proactive, those on placebo had 30% higher requirement of insulin therapy. So despite you see they didn't so well on placebo in terms of glucose control, they needed much more insulin therapy to keep up with the effects of pioglitazone in that regard. And if you compare, for instance, the durability or the sustainability of those drugs compared to one of the leading sulfonylureas, glycoside, you see, yes, with sulfonylureas, a very prompt and early decrease, but not very sustainable after a very short while. And this is what we just saw again, also derived from the UK PDS trial, this permanent increase year by year of hemoglobin A1C, which is much more durable control with beta gamma agonists. And this is A1C, and this is fasting glucose, where I said you see the most of the effect of those. Now comparing as add-on to metformin, which would be the typical thing, higher versus sulfonylurea, same phenomenon, very rapid drop in A1C with glycoside and metformin, and the sustainability long-term with the higher combination, and the similar things for fasting plasma glucose. Sorry, this was too quick. And also if you take in glibenclamide, one of the leading agents in the sulfonylurea class, you see the very same thing. So I think it's clearly one of the benefits of beta gamma agonists compared to other options, that you get good long-term metabolic control. Now, what about them? And this was a protocol questionnaire, insulin resistance as a predictor of cardiovascular events. Well, there is really a proof of concept trial on this, called the IRIS trial, and these are insulin-resistant patients. Now, just note, they didn't have overt type 2 diabetes. They were, of course, in a pre-diabetic state, but with a recent ischemic stroke or TIA. And if they were randomized on pioglitazone, you see a 24% reduction of the cumulative probability of events. So an effect more or less as strong as with statins you can get in those without overt type 2 diabetes, but clearly on the way to developing full-blown diabetes later on. And if you look at components of this stroke, myocardial infarction, for any of those, you see the benefit. And of interest is also look at manifestation of type 2 diabetes. Now, this is more than a 50% reduction, so you also prevent manifestation of diabetes in those patients early on. And there are other trials, as you surely know, that up to 70 or 80% reduction in randomized controlled trials you find with those drugs. Now, what about then the downsides? And this is particularly interesting. Heart failure, actually, in those was no significant difference. This is other adverse event, so-called serious adverse events. Again, heart failure, you see there's a trend, but nothing significant. Along with falls, this is one clearly of the downsides, more bone fractures and weight gain. At the same time, the liver enzymes are very much favorably influenced. So this is the indication for a healthier fat component, including in the liver. Now, the other line of evidence, as already alluded to, comes from the corrective trial, though we realized it was only the secondary endpoint, or composed of death, myocardial infarction, stroke, which was significantly reduced, so the cardiovascular benefit in that as compared to the primary endpoint of a rather complex primary composite. And of course, there's a learning curve. In any other of the cardiovascular trials, never ever leg amputation, for instance, has been included because it's largely due to neuropathy, infectious disease, but only to some extent also to vascular disease. And all the other components like revascularization have not been used in all the recent cardiovascular outcome trials. So we remember the inclusion were like in most of the cardiovascular outcome trials in recent years, people with established macrovascular disease, and the distinction here of the hard endpoints and the more softer endpoints physician determined. So it's clearly useful, and this is post hoc, and that means it's more hypothesis generation is a final proof. But if you focus on those with a previous stroke and then ask what happened in the trial, you clearly see an enormous benefit, 50% reduction of further fatal or non-fatal stroke. And the same thing, focusing on those with the previous myocardial infarction, 28% reduction. So I'm pretty sure if we would redo the corrective trial today with the appropriate endpoint, we would end up with a highly significant result. But even so, the stroke people recommended very early on that in patients with type 2 diabetes who do not need insulin start pioglitazone after a stroke for secondary prevention. And I think it's important here, we'll come back to that. The combination with insulin, this may be to be really abstained from. And what about then heart failure? Yes, there is around 40% increase in the corrective trial, but it's striking, despite the higher risk of serious heart failure with pioglitazone, there was no significant difference in the rate of subsequent all-cause mortality or the main secondary endpoint. In fact, you were much, much better off if you had a first heart failure event being randomized to the beta-gamma agonist in this extent. And of course, it's a complex situation. We all know insulin resistance is a driver of heart failure. There are very compelling amount of evidence that with more advanced heart failure, you have more advanced insulin resistance. There are prospective trials looking at insulin resistance as a predictor of that, and clearly that's an established fact. And of course, it's puzzling why we saw then the increased heart failure with pioglitazone in the corrective trial. Now, meanwhile, we all know we have to really do the cardiovascular outcome trials, and this was the unexpected thing with saxagliptin in Saber-Timmy, that we ended up with a 27% increase of heart failure events, and clearly neutral with sitagliptin, tepros, linagliptin, and carmelina. And then the striking and at first also unexpected reduction of heart failure events with all the SGLT2 inhibitors, and this really has conquered the world of medicine, including cardiologists, who are now going to treat people even without diabetes with those drugs, but preventing heart failure. And down here we can see with insulin, this is proactive, as mentioned, much less risk as compared to rosiglitazone in the RECORD trial. So we have learned to do the cardiovascular outcome trials, and we have also learned that these drugs, most of them have effects on renal sodium reabsorption. Well, of course, we rediscovered this with the SGLT2 inhibitors, but also insulin stimulates proximal and distal sodium reabsorption. There are several systems like the INAC system of a number of ATPases, and so these are similar effects as also with glitazones or beta gamma agonists, which act on the INAC system. So there is a negative synergy between insulin and glitazones. GLP-1 seems to increase natriuresis. Sorry, this was too quick. And mixed results. I'm not going into this. We can discuss this with the DPP-4 inhibitor. There are some benefits actually in terms of increased sodium excretion, but other actions which really counteract this. So what happened then in the proactive trial? And that's really interesting. After the first congestive heart failure event, looking at survival. So if you are randomized on pioglitazone but not on insulin, this was really the best option and benefit of outcome as compared to pio on insulin, as compared to placebo, no insulin, so better than placebo and placebo insulin. So it's very likely that the concomitant insulin therapy actually was driving the effects in the proactive trial. So, in fact, there is excellent pathophysiological proof that drugs like pioglitazone improve left ventricular diastolic function in subjects with diabetes. These were euglycemic insulin clamps in a randomized trial, 12 type 2 diabetes with 12 with normal glucose tolerance. You get metabolic effects, including blood pressure you would expect, and by improved whole body and myocardial infarction, insulin sensitivity, left diastolic function, and systolic function. And this is what we are looking at. So insulin sensitivity, the glucose infusion rate, and this is the mean glucose uptake into the heart muscle. And you see with pioglitazone that you, of course, increase glucose uptake into the cardiac muscle along with a better systolic function, and this is the maximal filling here. And this shows diastolic function is clearly related. If you reduce hemoglobin A1C, you improve that. This is cardiac glucose uptake, so insulin sensitivity of the heart muscle, and this is the whole body insulin sensitivity. So these are proven effects. And in fact, in this particular study, ejection fraction of the heart was improved, including also a bigger stroke volume in that. So if we compare for cardiovascular outcomes, but this is observational data, there seems to be an edge for pioglitazone favoring the use of that in people to prevent further disease. And in fact, there are mechanistic studies when you look at plaque stabilization in patients. And this was carotid ultrasound where you measure the echolucency. And this is driven by the lipid content of the plaques. And you see in a very short period of time, with pipa gamma agonists, you improve this. So you reduce the lipid content and you stabilize plaques with that. And there are further mechanistic studies looking at intima media thickening and intravascular ultrasound measuring the lipid core. And this is technology for carotid intima media thickness, which has been measured the intravascular ultrasound, and you measure the lipid, the atheroma area. No matter what technology, clearly in comparison with glimepiride, we see a significant striking benefit with the pipa gamma agonist. And of course, it impacts also on the lipids, as you would expect in that. Now, I think very important, the emerging drugs like dual pipa alpha gamma agonists, and there are very useful studies looking at non-alcoholic fatty liver disease. And what we see here, these are animals studies, so there's always a caveat how this translates to humans. But insulin resistance, this is normal chow. This is then this Western diet and sweet water, and this is vehicle. You see how you reduce insulin resistance and the impact of bio and thyroglitoside in that, and this impacts on triglycerides, the liver enzymes. Look, this is the indication of healthier fat in the liver. Total cholesterol, you find some reduction of normalization with thyroglitoside and an increase of non-HDL with this fatty diet and sweet water. Little effect with pioglitazone, but with thyroglitoside. And this is histology. This is the regular child. This is what it should be. This is vehicle. You see how you render the liver full of lipid droplets. Some improvement with pio, but even more with thyroglitoside. So that's a very important finding as fatty liver disease. Seems to be a very strong driver also of cardiovascular disease, a modifier and amplifier for the risk of cardiovascular disease. Now, when we measured more quantitative forms, they have histology. You also see on lobular inflammation in the liver, which is of course a precursor also of liver carcinoma, then also some benefits with pioglitazone, but more striking with the dual agonist. However, we all remember that the first of this dual pipa alpha gamma agonist made a big splash, and actually there was increase of death, and largely also due to heart failure events in this case. So it's important that we know what long-term the outcomes are, and there's actually one with another dual alpha gamma agonist, and you see the trial was prematurely terminated because of recommendation of the safety monitoring board and futility of benefits. Was a very well done study. You see a trend for the primary outcome with the active compound here, but non-significant. The rates of serious events and what you expect here. And this was a new thing, GI hemorrhages and also renal dysfunction. This comes probably from the alpha component. Here we know similar things also with fibrates. This is transient, reversible, but something to be taken into account. Now, if you look at the primary outcome, you see this was non-significant, but there were some favorable signs like hospitalization for unstable angina and unplanned coronary revascularization, which clearly are compatible with benefits. Now, if you look at the metabolic parameters, yes, glycated hemoglobin came down, HDL was highly increased, triglycerides reduced, but there was also an LDL effect. So it could be that there is a complex interplay between the various components of this duo. So we need to really go for the data, and actually there are some just published here comparing glucose efficacy, but also finding triglycerides, LDL-C, VLC, total cholesterol, and non-HDL cholesterol was significantly reduced and HDL was increased. So, but the message is it would be very, very helpful at least to do good registries to monitor cardiovascular outcomes in this result, which are not really published in this trial. So where is the place in the guidelines? And this will be very brief. Those drugs are very helpful for early combination therapy, maximizing efficacy in glucose lowering, but also minimizing side effects. And in fact, there is combination studies with incretin-based therapy. You see that you get more of the insulin component and reduce the insulin resistance. And if you look at what happened to serum glucose, you see the benefit of the combination. And in fact, on the left down there, insulin sensitivity really goes up. This is what you would like to do. And also the beta cell glucose sensitivity is largely improved with that, and you really stimulate also insulin secretion. And perhaps if you look at this consensus documents, ADA, EASD, we have learned the first question before we start glucose lowering is look at coexisting atherosclerotic cardiovascular disease and other things like chronic kidney disease or heart failure. Now, in fact, if it is there, then this gives an edge to the GLP-1 receptor agonist. However, if you're missing targets, then beta gamma agonists, and I've shown you the evidence that there is some reduction, and if you use them right, they're also safe in this combination. We would stay away for the other arm here, heart failure patients. So we need to monitor people for emerging heart failure. This is a regular thing, dealing with people with diabetes, but this is not the indication for a combination with that. And this scenario of compelling need to minimize hypoglycemia, beta gamma agonists are very useful, and also in terms of cost efficacy, there are very useful drugs here. Now, the ACE recommendation 2020 have done now the same thing, that they go first to differentiate coexisting atherosclerotic cardiovascular disease. What I like here is that they consider, according to the A1C, monotherapy, dual therapy, triple therapy, or other actions. And in that, they also give you the option in that, but when it comes to dual therapy, then those drugs are including, and I would bet in the next edition we will get more about the indication related to non-alcoholic steatosis hepatis, where you have in this combination a very durable glycemic efficacy. So I'm stopping here, and thank you for your